Hello and welcome to this Ask the Expert session. My name is Bedimo. I'm Professor of Medicine in the Division of Infectious Diseases and Geographic Medicine at UT Southwestern Medical Center. Today, I will be providing answers to clinical questions submitted after a recent educational program we had titled Staying Vigilant for Immunocompromised Patients, Insights from a COVID-19 Expert Working Group. Yeah, this is actually a very good question, and let's rephrase that question by discussing why drug-drug interactions matter with nirmatrelvir/ritonavir for about three reasons. Number one is that these compounds, especially the ritonavir that has to be given with the nirmatrelvir to extend its half-life, they limit the metabolism or inhibit the metabolism of a number of drugs, several drugs, through this cytochrome P453A4. For that reason, it's possible to have toxic levels of a number of drugs. So there are mechanisms that need to be done to avoid that. Number one, find another COVID-19 medications other than nirmatrelvir/ritonavir. And number two is pause the concomitant medication that the person is taking for the hypertension, the anticoagulant, and other things. And if that's possible and safe. And number three would be just monitoring the dose of these drugs because of the levels. So that is easy when the drug is given for 5 days, because we know that it takes about a couple of days for that inhibition to take over. And also it takes about 2 or 3 days for that inhibition to wane after you remove the nirmatrelvir/ritonavir. So you can pretty much time it. But there is an insidious other mechanism of interaction with those drugs, which is inducing the metabolism of some other drugs through a different pathway. That induction, however, other than the inhibition, lasts much longer. So if you take 10 days of nirmatrelvir/ritonavir, it's likely that you may now inducing the metabolism of some other drugs. So that may complicate things. What I will recommend people to do is either to go to the NIH COVID-19 guidelines or the Liverpool drug-drug interactions guidelines, because this could be tricky. But it's a good point. People with HIV, especially if that disease is not controlled, may have higher likelihood of the adverse outcomes of COVID-19. So it is important. However, it also is very important that the HIV treatment not be interrupted for obvious reasons. Now, the 5 days that the COVID-19 treatment with nirmatrelvir/ritonavir do last are not sufficient to require us to recommend alteration of an HIV regimen that also contains ritonavir. So the guidelines is to continue those. If it's a much longer course of nirmatrelvir/ritonavir, more than 10 days, for the reasons that I stated at the previous questions, it might be important to revisit this and ask an expert. Yeah, so again, to see if testing of the spike antibody titers is important, I imagine that the question is because of the possibility that immunocompromised people may not respond as adequately to the vaccine, and therefore testing might check whether they responded. Now, this is not recommended to be done clinically because there's no great clinical lab availability for doing that, nor has that been shown to be important in clinical setting. However, data is accumulating suggesting that some immunocompromised people, like hematopoietic stem cells transplant people, have very poor likelihood of responding adequately to COVID-19 vaccine. And then newer data suggests that giving them additional doses might actually compensate for that lack of response in most of them. So looking at the newest CDC guidelines for the monovalent vaccines for 2023 and 2024 is really consistent with newer data that an additional mRNA dose for these immunocompromised people would be adequate. So testing antibody titers, no, but additional doses, yes. Yes, actually, great segue to the previous question. How do I discuss the updated vaccine? Now, the first thing is that it's been updated to target the variants that are circulating now and might be updated yet again in the future, depending on what transpires. Number two is that, again, as I said at the answer to the last question, data is emerging suggesting that while many people, profoundly immunosuppressed people like hematopoietic stem cell transplant people, may not respond adequately to one dose of this monovalent vaccine, an additional dose is likely to bring the majority of them to respond. So that is the message that providers should give the immunocompromised people. And that question prompts me to say one more thing, is that the immunocompromised people are still struggling with the same concerns that the rest of us had in 2020 and 2021, i.e. the risk of acquiring infection is high, but they're not as well protected either by past infections or by vaccinations. So we should be vigilant about that. Well, my strategy to address COVID-19 fatigue in immunocompromised people is data and candid discussion of data. I know that there is a flood of disinformation and misinformation out there, but it's important to refocus and recenter to what we know and what risks remain. Immunocompromised people are still not as well protected by vaccines, as we discussed earlier. Another thing is that the sole remaining monoclonal antibody that were used to prevent as pre-exposure prophylaxis for COVID in immunocompromised people no longer works. So we don't have any molecule to prevent COVID in these people, and so they cannot, unfortunately, afford to be fatigued because they're still at high risk. And we should be candid about that discussion, even as they see that the rest of the world has opened up. Well, I think you looking at the barriers that would keep immunocompromised people from receiving an anti-SARS-CoV-2 monoclonal antibody in the future, and that barrier is the healthcare providers. A lot of people have had skepticism that this is a therapeutic modality that would ever be effective again, given the short half-life of the previous monoclonal antibodies developed. But I have great hope that there is the newer ones being developed, and that will be able to tackle the newer variants that are circulating, and that is a modality that has been incredibly helpful to keep immunocompromised people protected. And so we should dispel the myth and dispel the fatigue, as well as dispel the the misconceptions of providers. Yeah, virologic rebound has been an interesting concept, and let's also add to that the concept of symptomatic rebound, and the two don't always go hand in hand. Let me explain. A number of people who take who have COVID, the symptoms can improve and then recur. And if you were to monitor the viral load, which is not done in clinical settings, but in a research, you might find that some people's COVID viral load in the nasopharyngeal tract will go down and then will rebound. And this is more likely to occur, of course, in people who have immunosuppression, who may not have a drop in virus at all for weeks or even months on end. The concern has been whether the treatment that we provide people may increase the risk of rebound. And there is a very recent paper by Jonathan Lee from Mass General that have looked for the first time with very careful monitoring of the virus in a number of people after they received that treatment and with antivirals, and those who did not receive treatment, to see that viral rebound seems to be more common with some treatments. And I think these are the kind of data that we need to pore over more, understand whether that is something that is, like I said earlier, the previous studies did not show any significant link between that viral rebound and the symptom rebound. But it's important to know that in some people, again, especially immunocompromised, the virus may linger for much longer. And in some people, even the immunocompetent ones, the virus might rebound. Well, can antivirals prevent post-acute sequelae? This is a very important question in my view, because if you look since the beginning of the pandemic, the goals of care for COVID-19 and all that was studied in trials and cohort studies is how to prevent getting sicker, hospitalization, and death in the 30 days after you get infected with SARS-CoV-2. Now, those are over the years, we've seen the likelihood of that occurring decreasing over time. So when in 2020, it was about 15% likely that you will be hospitalized or die if you were to acquire COVID. Now it's probably 1% or so or less. Now, so this has led a lot of people to think that it may not be necessary at all to get tested or treated because it's so unlikely to be hospitalized or die, especially if they don't have the risk factors. However, they just might be, according to newer data, yet another goal of care for COVID-19, which is prevention of post-acute sequelae or long COVID. Now, this could be a game changer if that was confirmed, and that would convince a lot of people to take antivirals during the acute phase, if indeed there was a possibility that the risk of developing long COVID, which could be very debilitating, would be reduced by taking the antivirals during the acute illness. Thank you for your time today. I hope you found this information helpful. Please subscribe to the Exchange CME's YouTube channel and check back regularly for updates on COVID-19.